Good afternoon, and welcome to today's presentation at Community Medical School. My name is Bob Peratini. I'm the Chair of Psychiatry and a former presenter here at Community Medical School. And it's my privilege tonight to introduce our speaker. Dr. David Ritu is Associate Professor of Psychiatry and Pediatrics. He has many roles here at the Medical Center. He directs the Pediatric Psychiatry Clinic in our department, and he's also the training director for our Child Psychiatry Fellowship. He's a graduate of the UVM College of Medicine, and he completed both adult and child psychiatry training at the Harvard Medical School. He has always been an achiever. He won the Sweetser Prize for Excellence in Psychiatry as a medical student, and he was the first recipient of the University of Vermont College of Medicine Physician Scientist Award when he returned to Vermont. Most important to us today is his research interest in the role of temperament and personality factors in childhood psychiatric disorders. He has published over 100 journal articles, chapters, and scientific abstracts on this subject, and you're about to see for yourself that he's an excellent speaker. I don't know if he plans to plug his book, but I'm going to just go right ahead and plug it for him. It's titled Child Temperament, New Thinking About the Boundary Between Traits and Illness, published by W.W. Norton. And if you want to read more after tonight's presentation, you might want to find that book. And you also might want to check out his blog on the UVM website. So now, without further delay, let me present Dr. Ritu, whose presentation is Personality or Mental Illness, Understanding the Links Between Traits and Disorders.
Good. Okay. How's it sound? Does that sound okay in the back? All right. Well, hello, everybody. I'm really thrilled to see so many people here, and I'm delighted to be here. Thanks for the introduction, Bob. Thanks to the planning committee for picking this topic and inviting me to come. I'm really thrilled to do it. And I'm really going to do my very best in the next hour to make your time feel well spent here. As Bob was saying, like many of the faculty here, I do 12 different things. I see patients, I conduct some research, we run a program to train young doctors to be child psychiatrists. And one of the things that I've become more interested in lately is educating not only medical students and residents and fellows, but also the general public. Because I've gotten the impression that there's a lot of good information that people don't hear about, and there's a lot of bad information that people do. And so I'm hoping to try to present a viewpoint that I hope you'll find interesting and important. I'm also trying something new in my delivery. I used to, I started speaking using note cards, and then PowerPoint came along, and then I got onto PowerPoint like just about everybody, and had presentations with 100 slides. And now I'm going back to using note cards and as few slides as possible. So I think there are perhaps 20 slides in the entire presentation, and we'll see how that goes. I'll be talking about not only some of the research that I've been involved in, but research that's being conducted all over the world. So I will say, in terms of disclosures, I don't receive any money from the pharmaceutical industry. But in full disclosure, I do have to say that I did write a book that includes this topic and several others, and I am in the process of actively promoting that book. So I just want my ulterior motives to be very clear to everybody. Like most people here, we don't work alone, and I'm just very grateful to be involved with a great team at the Department of Psychiatry, the Division of Child Psychiatry, and the Vermont Center for Children, Youth, and Families. It's a great group of people. These are the names and faces of some of them. There are many others that are there as well. And it's a really talented and fun group, and it's a privilege to be a part of them. All right. So this is a topic that I've been interested in, the links between what we call a trait and what we call a psychiatric disorder or a symptom for a long time. And it's been really gratifying to see that it seems like just in the last 6 months to a year that a lot of other people have gotten very interested in this topic as well. And what you can see on the screen is just a sampling of headlines and photos that are all over the place. I'm not really quite sure why people have suddenly become so interested in this topic. Maybe some of you can educate me about that. I've got some theories. One of them is, unfortunately, we keep running into these horrible tragedies regarding mass shootings. And they're horrific to hear about. I was glad to hear about one that finally got averted, I think last week. And usually one of the first questions that everyone seems to be interested in, the media certainly asks, is, was there a psychiatric diagnosis? Was the shooter taking medicines? And it makes me wonder what's behind that question. What are we trying to understand by that question? Are some people asking that question as a way of trying to create some distance between, people who perform horrible acts and ourselves? Another reason that I think people are getting really interested in this topic is that there's been a lot of studies, and perhaps you've seen some of them in the media, that are basically saying the same thing, which is that the rates of psychiatric disorders seem to be going up. It seems like every week the New York Times is writing something about that, and it certainly seems to be true for attention deficit hyperactivity disorder, or ADHD. Certainly seems to be true in autism, and it's true in a lot of other things. And as these studies come out that tend to show more and more of people who seem to meet criteria for an illness, there's sort of a reaction to that. And there's people who claim that couldn't be true. That can't be true. That's because the pharmaceutical industry is making this up. That's because we're now pathologizing everything. Why can't somebody be just, and I'll get back to that word just, why can't someone be just sad without being depressed? Why can't someone just be active without being hyperactive? And I think what's making people uncomfortable about this, and what's behind this concern about what some people consider to be overdiagnosis, is overtreatment. I think now we have pharmaceutical industry, we have advertisements now that directly market us, and we see them on television, and that's not something that was with us in the past. And so people are wondering if these medications are appropriate. And there continues to be frustration within psychiatry, both those of us within the field and outside of it, that we still have not made the progress that we would have liked to really define what a psychiatric disorder is. We still define our disorders by a constellation of symptoms that seem to hold together. But in other areas of medicine, at least some of the disorders are defined more precisely in terms of the mechanism that causes those things. And that's causing some frustration and, I think, some skepticism. And then finally, just in May of last year, the official book that provides the official diagnoses of psychiatric illness came out after 20 years. The new edition after 20 years came out, the DSM, and we now have the DSM-5. And in it were a lot of disorders that changed somewhat in terms of their definition, and a few that didn't change very much. And now there are new disorders that didn't exist as much. So all of these things, I think, are swirling together to create this interest in this controversy. So what I'm going to do, I'm going to try to divide this talk into 3 parts. The first will be a crash course in temperament and personality that just basically brings people up to speed on some of the core features. Talking about temperament and personality is a course in and of itself. And then we're going to get right into the sort of the meat of the issue, which is, what do we know about how traits and disorders are linked? What may be behind that? And then the third part that I want to leave plenty of time for is, so what? I mean, yes, this is an interesting thing to think about, but does it really change anything? Does it really impact our practice? Does it really impact what we do or how we think about these things? And I'm going to try to argue that it does in a very profound way. So I'll start with a definition of temperament. I'll try not to use a lot of technical jargon, But basically, temperament refers to the typical way that a person interacts with the world. And there are people who tend to get riled up easily. There are people who tend to not get riled up pretty easily. And the definition of temperament continues to be debated, like a lot of things. For something to count as a temperamental trait, generally 3 things are agreed upon. It needs to be something that comes up early. How early? That would be in infancy, as a toddler, and I'm sure there are moms who will tell you that they knew the temperament of their kid in the womb. There needs to be at least some genetic influence on that trait. There's been a bit of a myth that suggests that temperament is purely genetic, and I'm going to show you that that's not correct. And then there needs to be some stability. So a trait needs to have some stability over time. That doesn't mean that it's destiny. That doesn't mean that a shy baby is going to be necessarily a shy adult, but there is some predictive value of looking at a trait over time. The concept of temperament has been around for a long, long time. There was a famous Greek philosopher named Galen. Some of you may have heard of him, and he basically postulated that you could predict what somebody's personality was by the concentration of different substances, or what he called humors, that were in the body. So things like yellow bile and phlegm and blood. Basically, if you had more or less of one of those, you had more or less of one trait. And in the modern world, when we talk about that, we all chuckle and think that we're really so much more refined. But I would argue that if we substituted, black bile, phlegm, and blood with dopamine, norepinephrine, and serotonin, we haven't really changed that much. And then I think a great analogy for temperament, for those of you who are musically inclined, is if you think of a person's life as a piece of music, as a symphony perhaps, the temperament is the key that music is in. So there are unlimited possibilities of what that piece of music will sound like. But if you listen carefully, you can definitely hear the difference between a piece of music that's in G major versus one that's in A minor. And that key is, I think, a nice analogy for what temperament really refers to. And temperament does not exist just in people, as you all know. It exists certainly in non-human primates. It exists in dogs. In fact, dogs are bred in part because of their temperament. But there's literature that goes even well beyond dogs. In fact, you probably aren't aware that there's a vast literature on the temperament of guppies that people study and read about. So many different types of species have temperament, and people will argue about what the evolutionary value of different types of temperament are. I'm using the word temperament. A lot of people I also use the word personality in my talk, and I just should also say from the outset that I'm going to use those 2 terms somewhat interchangeably, and purists of temperament and personality research probably wouldn't like that. But that would be an entire talk in and of itself to talk about what the difference is between temperament and personality traits. There is quite a bit of overlap, and generally when people speak about traits in kids, especially little kids, we use the word temperament. When we talk about adults, we tend to use personality. So I will be going back and forth between those 2 types of. So for people who were psychology majors, I don't know if there's any psychology majors in the room, the term temperament is almost synonymous with 2 people, which is Alexandra Chess and Stella Thomas. And they were 2 child psychiatrists. They were trained in the Freudian view of psychiatry. They did their work in the 60s, 70s, and 80s. And they did an observational study of about 120 kids. I think they were mainly upper class kids, and then followed them over time. And based on, let me just go back here for a second. And based on their observations, they came up with a temperamental theory that postulated that you could define temperament according to these 9 traits: activity level, rhythmicity. I won't go through all of them, but you can read them. They also postulated that these different types would fit together in particular ways to create types, so that there were a group of kids who seemed to have this combination of high activity level, low rhythmicity, low adaptability. And so there was this sort of dual way of looking at it in terms of dimensions, in terms of types. And the 3 types that they hypothesized the most famous one, the most enduring label that's gone on is the difficult child, right? We've all used that term, maybe not always knowing exactly what that meant. The other cornerstone piece of their theory was that temperament traits were not good or bad by themselves. But what made them work or not work, what made them adaptable or not so adaptable, was how well they fit with a particular environment. And that was the goodness of fit theory that people still talk about today. And we will talk about later in the talk when I show you some research about that. Now, fast forward 40 years or so, a lot of people think that basically temperament research kind of began and ended with Thomas and Chess. And really nothing could be further from the truth. There's been an unbelievable amount of research in temperament and personality, and just lots of knowledge that we didn't have before. There still is quite a bit of a debate on a lot of the core features of temperament. We still don't even know exactly what the core features are, and part of the problem has to do with politics. So if you are a big cheese in the world of temperament or personality research, generally what you do is you create your own structure, you give the dimensions your own names, you create your own scale, and you do research with your methodology. So for people who try to read the literature and look at lots of people's work, it's not always clear how well one scheme sort of maps onto another. But generally there is agreement that there are at least sort of three major core dimensions of personality. One of them has been called negative emotionality, negative affectivity, sometimes neuroticism is more of a classical term. It generally refers to how easily somebody is brought to experience a negative emotion. Right? There are people whose boats get rocked pretty quickly and people where it takes a lot to rock their boat. And when somebody gets upset, they get really upset, they get really scared, they get really angry, and it can last a long time. That's considered to be one of the major dimensions. Another one that's been called extroversion or surgency refers to more positive emotions. So how excitable somebody is, how social they are, how much they like to be the center of attention. They like to have lots of stimuli around them. And the third dimension is more of a regulatory dimension. It basically refers to how easily somebody can keep your emotions and your attention and your behavior in check when you need to, when you're trying to work towards a goal, or when you're getting upset but you don't want to really express that. That regulatory dimension has been called lots of things. Some people call it more kind of persistence. It's been also called effortful control. There's a lot of different things. And those dimensions can configure in different ways to create, again, different types, kind of like the difficult child. And this is a slide that goes through what those types are as I read it from the literature. So the largest type is called the moderate group. And those are people who generally have average levels of most of the major traits. In the literature, it's often called the unremarkable group, but I find that a little pejorative. You wouldn't want to be known as having an unremarkable personality. So I think moderate is a little bit more palatable. There's a confident group, and the confident group folks are low in negative emotionality, high in extroversion, have good regulatory skills. There's an anxious group, higher in negative emotionality, lower in extroversion, lower in regulation. An agitated group, which is high in both negative emotionality and in extroversion, low in regulation. And what I've called a mellow group, low in negative emotionality, low in extroversion, and with moderate amounts of regulatory ability. So whenever I show this, people sort of then try to think, okay, I'm in this group, and my spouse is in this group, and my kid is in this group. I think a lot of this can fit. It should be worth noting, though, that a lot of people don't fit into any of these categories really well, and that's always been the case. In fact, even with Thomas and Chess, they said that about a third of their kids didn't readily fit into any of the groups that they had defined. And I would also mention that, just like Thomas and Chess said, there are at least what our culture considers to be good and bad things about all of the major traits. So, for extroversion, for example, a lot of people really value the excitability, the animation of people who are highly extroverted, but they're not always sometimes they can fly off the handle a little bit. Sometimes they're not always the most organized. Those traits often go together. Negative emotionality, these are folks who may be prone to experience anxiety more easily, but on the other hand, they can be really sensitive to other people. They can be very kind. They can be wonderful friends. And I point that out because a lot of times when you find people describing the ideal something, the ideal spouse or the ideal kid or the ideal partner, you'll see people split those dimensions right down the middle. And they usually use it with the word but or yet, right? So I'm looking for somebody who is really exciting but very responsible, right? I'm looking for somebody who is very sensitive but very assertive. And present company, excluded, of course, those can be difficult combinations to find. And generally, we come prefix, even though we would love to be able to kind of choose traits more a la carte. And that's something to keep in mind when we're thinking about how do we work with kids, how do we work with families, how do we embrace the entire temperament of somebody and not trying to just pick and choose things. Now, I'm not going to go into a giant review of neuroscience, but I did want to just have I just wanted to have this one slide up here. There is a tremendous amount of neuroscience research that is taking place on temperament and personality, not as much as with the disorders themselves, but still quite a bit. And this is a flavor of what it may look like. So this was a study, this is what's called a functional MRI study. So this is a study that looks at activity levels in certain areas of the brain. And specifically, it looks at how the brain is connected. So if one area of the brain becomes active, what other parts of the brain become active? So in this study, they found this area down here is an area called the amygdala. And this area in blue and red is called the anterior cingulate gyrus. And what they found is that the degree to which a person, the term that they used was harm avoidant, but it's really sort of people who are temperamentally more or less anxious, people who get upset easily, people who get overwhelmed easily, had a lot to do with how much these two areas of the brain talk to each other. So for people who were low in this trait of harm avoidance, when the amygdala fired, sensing some kind of stimulus, the anterior cingulate fired as well, and then there was a negative feedback that then regulated back to the amygdala. For people who were more anxious, these two regions were more independent. So the amygdala would fire. The anterior cingulate was not as connected to the amygdala, so it didn't respond, and the amygdala activity was more unchecked. So this is an example of how temperament traits may actually look when it comes to the brain and when it comes to neuroscience. And thinking about our big question today, you may say, hey, I've heard about the amygdala. Isn't the amygdala also important when it comes to things like depression and anxiety disorders? And the answer is yes, it is important. So already we're getting a clue that we're talking about the same areas of the brain, both when we talk about disorders and when we talk about traits. Now, what about genetics? How heritable are temperamental traits? Like I said, I think there's a myth that a lot of people think that temperamental traits are all genetic, and they're not. And in fact, there was an idea that if you wanted to study a pure genetic trait, grab a baby, because you can study them before the environment's had all its effect, had a chance to change behavior. And it turned out that didn't really work at all, and that a lot of traits in infants have a very strong environmental component. And in general, summarizing a lot of literature and oversimplifying it to some degree, most studies show that the major dimensions of personality and temperament have contributions of about equal amounts of genetic influence and environmental influence. The other thing I would say about that is we tend to think of that as a static number. Oh, okay, extroversion is 60% genetic. And we have to remember that the amount of heritability changes in regard to a lot of different factors. So heritability can be different between men and women. It can be different in different cultures and environment. And it certainly can be different across different ages. And some of the ways that it works is a bit counterintuitive. You might think that the older you get, the stronger the environmental influence is. That would make sense. But it actually turns out that in some traits, and in this study, this is one of the things that we showed, that the amount of genetic influence actually increases as somebody gets older. So you've all heard that expression that you sort of end up becoming your mother. My mother is here today, so I can say that. So there may be some genetics behind that idea. There's also some studies that show that in terms of temperament change and personality change, that there can be quite a bit of change until you hit 30. After 30, what you see is pretty much what you're going to get. Whenever we talk about genetic and environmental influence, though, I always hesitate a little bit, because one of the things that has really drastically changed in the last 30, 40 years is how we understand, the age-old nature versus nurture debate. And for many years, it really was sort of nature versus nurture. There were people saying, I think this behavior is driven by genetics, and other people say, no, I think it's driven by environment. And through a lot of research and a lot of arguing, it then moved to this idea that it was nature and nurture. So that, like I just was telling you, that extroversion or negative affectivity looks like it might be about 50-50. But that still doesn't quite get to what we're really talking about, because it implies that these are different pathways, that there's sort of a genetic pathway into the brain and there's an environmental pathway, and they kind of share space, but they're different pathways. And one of the things that I think we're really learning right now is that genetic effects and environmental effects are mutually interactive. They change each other. And there is some really amazing research going on right now that shows that, for example, certain environments or certain experiences, it doesn't change your DNA code, but it changes your gene expression. So a direct genetic result from an environmental event. And similarly, based upon somebody's genes, those genetic influences may actually cause certain environments to become more likely. Right? So you may be genetically predisposed to be exposed to a certain environment, and then that environment will have an effect. And it sounds very complicated, but we all know this, right? We all talk about, having some people bringing out the best of you or people bringing out the worst of you. So these are concepts that I think are being around. Science it's taken a while to really, I think, get it and to really grapple with it. So let me use an example here on how this all may work. And this is how we think. When we're seeing somebody, when we see a family who comes to their office, they're worried about the behavior of a child, and we're trying to understand how somebody got to that place. This is often the way it can be. And I'm going to use, it's spring, so I'm going to use a baseball example. And if anybody had ever seen the movie with Steve Martin called Parenthood, think about that. If you remember, he played a baseball coach, and his son was on his team, and his son was a kind of an anxious kid, and he was really antagonizing about whether or not he should put his kid in this high-pressure situation because he couldn't bear to see what would happen if something bad happened and he dropped the ball or missed. But let me explain how some of this can work. So let's start with a child who is predisposed to be more anxious than others. And let's say that he's on a team. He's about to play baseball, and he's getting really nervous. And the coach puts him out there, right? He's playing first base now, and he's in a pressure situation. So then what happens? What kind of thoughts do you think that child might have? Well, that temperament can relate to a lot of anxious, negative thoughts. Oh, please don't hit the ball to me. I'm going to drop the ball. Everyone's going to hate me. These are the kind of things that anxious people, that swirl around their head. And what do you think the effect of those thoughts are? They have real behavioral results. Maybe this boy starts shaking. His muscles start to tighten, so he can't really react so quickly. And what happens? What happens if the ball gets thrown to him? He's actually more likely now to actually drop the ball. Right? And so let's think what would happen then. Big pressure situation, the ball is thrown, he drops the ball, he feels horrible. The parent is sitting in the stands, and if you've been in that situation, you know how antagonizing it is watching your kid, hoping that they're going to do okay, and how hard it is when a child is really struggling in a situation like that. So maybe the child gets really upset with himself, and the parent becomes upset too. And the child says, that's it, I'm not doing this anymore, I don't need this, I'm not going to play baseball anymore. And a very natural response to that is to try to protect your kid and not expose them to that situation and say, yeah, okay, let's do something else. And so that's it. The season ends, they're not playing baseball anymore. But other kids are playing baseball. And so now that kid is not having the opportunity to have his skills develop, yet he still sometimes gets thrown in those situations. So he becomes more anxious, and he becomes more avoidant, and he doesn't get an opportunity to be in a situation to master those. So this is the kind of cycle that I think illustrates, how things can work in a negative way, and how genetics and environment all can conspire together to create, a situation that I'll see in my office or that people will struggle with as parents. All right, so that's a little bit about sort of the background of temperament and personality. I want to sort of get into sort of the main issue about how do we understand these links and how do we draw the line. And let me just give a very brief history of how this all worked together over the years, because people have conceptualized this issue in different ways over time. And I am anything but a Freudian expert, but I think I am safe in saying that back in Freud's day, he did believe that the powers that caused someone to develop psychiatric symptoms were exactly the same processes that were involved in regular personality traits. So there was very much this link between the processes that would lead to traits or disorders. And then there was this period in the 1900s where there was a lot of interest in personality, people were studying it, but it was more sort of the land of academic psychology. And psychiatry was sort of, they may have been across the street, but they weren't really listening to this. And the two worlds of psychiatric disorders, people studying psychiatric disorders, people treating psychiatric disorders, and people studying traits was very much separate. And then Thomas and Chess came into the world, and they did their landmark research saying, no, let's bring this back. I really think temperament is very important and is playing a major role in the development of psychiatric illness. And while now it sort of sounds like, okay, that's not a particular controversial argument, it actually was at the time. They took quite a bit of heat for that. Because if you remember, the two dominant forms of thinking at that time were one more the Freudian psychoanalytic perspective, and they didn't quite like the idea of innate traits. And then there were the behaviorists who believed in the blank slate approach, that everything was about learning and teaching, so they didn't really like it either. So they were a bit homeless in their ideas, but research continued, and they found more and more support for this. But then we hit the 90s and the decade of the brain, and psychiatric disorders became incredibly medicalized. I think perhaps our field was very eager to show that we were legitimate doctors. And there was an advent where there were lots of medicines that were suddenly on the scene, and we could treat this and we could treat that. And very much the concept that was marketed and the concept that was taught was that psychiatric disorders had nothing to do with your personality. So that the way depression worked is that you're going along, you're happy, you're a very happy person, and then boom, you get hit with depression, kind of like the flu. Or panic disorder. I even had a mug that said panic disorders come out of the blue. So panic disorders had nothing to do with sort of being more anxious in general. They would just hit you out of nowhere. And while there are certainly examples where that's true, I think there's a lot of people where that's really how it works. It's probably not the way it works for a lot of other people. So now we've gone into this era where we're really understanding and appreciating these links a little bit more, and now trying to understand exactly how they work. And one of the things that I think is really central to this whole argument and this whole idea is that even though we are taught to consider psychiatric disorders as a yes or no thing, right? You have depression or you don't have depression. You have ADHD or you don't have ADHD. The research has shown overwhelmingly that if you are able to measure symptoms in a quantitative way, almost everything that we deal with in our field exists dimensionally. And this is a picture that shows that phenomenon when it comes to activity level and hyperactivity. So what you see is this, beautiful bell-shaped curve in terms of activity level. It's not like there's a cluster of people here and then, oh yeah, there's the folks with ADHD out there. That would be too easy. So it looks kind of like blood pressure, or it kind of looks like height, or cholesterol levels, or a lot of other things that live in medicine that exist on a dimension. You know, it's important to remember this is not just psychiatry. A lot of the things that bring people to the internist's office are also dimensional. So then the matter is, what we have to do then is set this, what I call a speed limit, and decide, you know, so where does ADHD begin? You know, what is that boundary? What is the 140 over 90, you know, that boundary for hypertension when it comes to ADHD? And that can be really tough. And I sometimes use the analogy that diagnosing ADHD is a bit like diagnosing somebody as being tall. And we don't have very good benchmarks to decide, you know, where that line should be. So this would be a line that maybe would capture maybe the top 5% of people. Is that a good line? I don't know. Maybe and what's been happening, and what's clearly been happening, is that the line has been moving, and the line has been dropping. And so that more and more people are now qualifying for a psychiatric disorder. And I think that this is not controversial that this is happening. What is controversial is two things. One, is this really the only reason that the rates of psychiatric disorders are going up, or could there be other reasons? And there probably are other reasons. And then two, what people really get heated about is this a good thing or a bad thing? And a lot of people argue that this is a good thing. It's bringing more people to treatment. It's letting people get help more. Other people are saying this is a really bad thing because it's leading to unnecessary treatment, specifically unnecessary medications, and it's now pathologizing everything. You know, and there's no way, for instance, some people argue that ADHD could affect 10% of kids. Just, it can't happen. So that's what we're dealing with. And I will point out that I think it's interesting that psychiatry gets this criticism in a way that other areas don't. So if I were to ask people to raise their hand, and I won't because that would be a major HIPAA violation. But if I ask people to raise their hands, who have ever been diagnosed with an orthopedic problem? Probably a lot of hands would be raised. But nobody's saying, oh my God, these fractures? They're making that up. There's no fractures, right? Or if I said, how many people have ever been diagnosed with a pulmonary problem, asthma, bronchitis? A lot of people would raise their hand. Does that mean that we're making up pneumonia? I don't think so. But for some reason, there's a double standard when it comes to psychiatry. And while I really think that the question of over-treatment is a very legitimate argument and something to be talking about, to me, it's a twisted logic to deny, to say, well, I'm nervous about over-treatment, so I'm just going to say that these things can't really be real. So this is the quandary that we have about us drawing this line. And when I was in residency, it was acknowledged that these things were dimensional, but the solution was actually quite simple. And so the way I was taught was that you could distinguish between a trait and a disorder actually by one word, and that word was impairment. So something was a trait if it was just the way they are, and they didn't want to change it. It didn't bother them. It didn't hold them back. Something was a disorder if it caused problems. That makes a lot of sense, and it works in some ways. There's a big problem with the impairment benchmark, however, is that when you really study impairment, you realize that impairment itself is a dimensional construct. So people, for example, who are really, really depressed are quite impaired. People who are not depressed at all are not impaired. People who are a little depressed can be a little impaired. So it doesn't help you as much as you hoped it would. The other way we were taught to distinguish is the change. This is a change from your usual state, right? You're going along and you're not depressed, you're not anxious, and then you are. There's a difference. There's an episode. And again, that works. I mean, that actually can be true for a lot of people. I'm not here to tell you that I think, this is the way to understand all of psychiatric illness. But when you think about this, when you scrutinize it a little bit more, that benchmark also falls apart. A lot of the things that we deal with, autism, schizophrenia in some cases, ADHD, it's hard to find that time when things are different. a lot of times when I ask, and I always ask this question, if I'm seeing somebody for an ADHD evaluation, I say, well, when did the problem start? And the parents will say, it always started. I just expected for it to get better. It just never got better. So that tends to fall too. And I'd also say the impairment question also gets really tough when you deal with kids, because the question is, who's impaired? When I ask my 7-year-old kid if he considers himself to be impaired, he usually doesn't. He's fine. It's the teacher who's considering that there's an impairment, or it's the parent that thinks that there's impairment. So these things that we've been trying to hang our hat on just don't seem to work as well as we would hope. So here's acknowledging a busy slide. Basically, this is a summary slide that shows the relation between particular traits and particular disorders. And if you see something in red, that means higher level of the trait is associated with higher levels of the disorder. And if you see something in blue, it means higher levels of the trait is lower levels of the disorder. So it may be that this simple idea that a trait and a disorder are really the same thing doesn't quite hold up either. And we have to actually be considering multiple traits together. So for instance, what I mean by that is it looks like the relation between a trait and a disorder is different depending on what trait we're talking about. So this dimension over here, this regulatory dimension, this seems to be low in almost every single disorder that we can find. So this seems to really have something to do with the severity of problems, and it doesn't really matter which type. It's low, it's always low. If you look at extroversion, it's a very different story. In some disorders, extroversion seems really high. In some, it seems rather low. And in some, it doesn't seem to matter. So maybe a better way to think about temperament and disorders in some cases is to think about this profile of temperament. So that depression may be thought of as a combination of low extroversion and sometimes low regulatory. And ADHD may be more high extroversion, low regulation. So adding another layer of complexity for how this all may work together. Another challenge, and I'll just mention this briefly because I don't want to get too technical, but another thing that when we do this research we realize that makes our life even more complicated is that when we actually looked at the definitions of things, the language that's used to describe a trait and a disorder are often very, very similar. So if you take a personality scale, one that we use, and you're trying to calculate somebody's novelty-seeking score, one of the items on that questionnaire is gets into temper tantrums for kids. And if a mom checks yes, that's a point for novelty seeking. There's a disorder called oppositional defiant disorder. One of the criteria for oppositional defiant disorder is often gets into temper tantrums. So when we use the exact same language to define a trait and define a disorder, you can see that we're running into trouble and that things get very complicated very quickly. Now, what about this idea of goodness of fit? Maybe we even have to expand this idea of how temperament works with psychiatric illness to go even beyond the individual, and now let's look at a larger system. Now let's look at that goodness of fit and whether or not something becomes a disorder because it's a poor fit with a particular environment. And so we've done some of that research. This was a study that we did. We were trying to understand the link between the trait of novelty seeking and having attention problems as defined by the parents and by the school. And we did temperamental assessments and personality assessments of both the parent and the kid. And what we found is if you were a child who was pretty low on novelty seeking, you didn't have a lot of attention problems. And it really didn't matter what your mom was like. Your mom could be high or low. You had low attention problems. But if you were a kid who was high in novelty seeking, the way your parents acted mattered quite a bit. So if you were a low novelty seeking child with a high novelty seeking mom, if you were a high novelty seeking child with a low novelty seeking mom, you had very average levels of attention problems. You put high novelty seeking mom with high novelty seeking kid together, there were a lot of attention problems. So that actually argued that there was something to this goodness of fit, that really it did matter and that certain things may become more problematic, more looking like a disorder in the context of particular families, maybe in the context of particular schools. So this is sort of where we are now. And I think it's really not a controversial topic anymore to sort of say that we think these things are linked. And what people are trying to study now is how are they linked? How do we understand these relations? And there are all these models that are out there. Some of them are what we call a spectrum model. The spectrum model basically says, okay, I give up. It's all one big continuum. Right? The only difference between a disorder and a trait is a matter of degree, and that's it. And that may work for some things. I think probably the argument for that in ADHD is probably stronger than anything else. There may be more of a risk model. The risk model says a temperamental trait is a risk factor for an illness, but they're not the same thing. And probably a good example of that would be high novelty seeking and substance use. So substance use is not just high levels of novelty seeking, but people who have high novelty seeking may be more likely to experiment. There's a couple models where they sort of have a more mutual influence, where one is causing the other. They're both causing each other. That's often called the common factor model, or more of a bidirectional model. And then there's even what's called the SCAR model, which is the risk model on its head. And that's basically saying that it's not the trait that's a risk factor for an illness, it's the other way around. The illness is actually driving personality change. And the place where we see that is in things like Alzheimer's. Nobody argues that the personality traits that sometimes you see very early in the course of Alzheimer's is causing Alzheimer's. It's more that the whatever's happening in the brain with those plaques and tangles is actually influencing personality traits. So there's a lot of different ways it could work. It could work in different ways for different disorder trait combinations. And it would be great to really simplify this, but unfortunately the brain is really not that simple. The question that I'm really interested in right now is, so if we accept the idea that on the surface, on the behavioral level, that there is this continuum, that there's just sort of this smooth distribution from activity level to hyperactivity level. To me, the million-dollar question right now is, does that work on the level of the brain as well? In other words, do the mechanisms that cause a trait, is it just those same mechanisms turned up or turned down that cause the disorder? Or is there actually something different about people who experience a disorder level of problems? And just because you see this beautiful normal distribution, you can't assume that the underlying cause is exactly the same too. An example would be if I got a million people to give me a blood sample, and I measured everybody's hematocrit, how much blood, what your blood level was, I'd get a nice, beautiful, normal distribution. And I might be tempted to say, well, that means that the underlying cause of that is the same. It's just being turned up or turned down. But we know that wouldn't be true, because we know that there would be some people at the very bottom end of that curve with very low blood levels who are bleeding, who have a hole in their body somewhere. That's a very different event than why someone might be having an average or a slightly lower blood level. And psychiatry, we do not know whether or not this is, to what degree this is true in the things that we deal with. And there needs to be more study about that. There are some. This is a study that showed from a twin sample that it looks like about half of the genes that are important in determining the trait of neuroticism are exactly the same genes that underlie depression and anxiety disorders. So half. That's a lot, but it also shows some differences. So this is where I'd love to see more attention paid. And this is also where I end up having trouble with this argument. What you'll hear when you hear this criticism about over-pathologizing things is people say, well, it's not ADHD, it's just X. It's just their personality. It's just laziness. They're just sad. And to me, the million-dollar word in there is, what does just mean? When you're saying something is just sad, do you imply that it's not brain-based, that it's their fault, that there's nothing you can do about it? What does just mean? And we really do not have the evidence to justify just right now. So the bottom line here is that we've got a lot of words out there. We've got a lot of labels: personality, temperament, axis 1 disorders, personality disorders, organic conditions. And we all have to remember, and I tell our medical students this all the time, we have to remember that all of these words have to live in the same brain. It all has to, we don't have the personality part of our brain and the disorder part of the brain. It's all the same brain. Okay, so the last part is, I hope you found that interesting and thought-provoking. But now the question is, well, so what? How do we operationalize this? What do we do about it? Why do we really care? And in our clinic here at UVM and at Fletcher Allen, I think we really incorporate these principles in our day-to-day work. We have an approach that's called the Vermont Family-Based Approach. It was developed by the director of our division, Jim Hudjack. And it really, among other things, really uses this idea that traits and disorders work along a continuum, and that it's not easy to sort of draw the line. And when kids come in to be assessed in our clinic, rather than just sort of saying yes or no, you meet criteria for a disorder, we actually don't we don't spend as much energy on what you actually qualify for, the labels that get applied. What we're really interested in is, are the degree of problems along different areas, where do they stand relative to other kids? So this is a profile from an instrument that we use. And basically, this is a 10-year-old boy. And so this will be a printout, and this is maybe based on what mom says about this child. How much anxiety, depression is there? How much attention problems there? And because this instrument is normed, we can compare 10-year-old boys to other 10-year-old boys. And we can say something like here, in this case, this boy has a level of attention problems that's in the 95th percentile compared to other 10-year-old boys. Now, is that ADHD? I don't know. I mean, it's the 95th percentile. Do you think that if you were a kid and 95% of the kids in your class had a better attention span than you did, that might cause some problems? I think it probably would. Do you think if you were in the 85th percentile of attention problems, that could cause some problems? Yeah, it might. Maybe it depends on other factors. Maybe it depends on intelligence or supports at home. So we get a little less hung up on saying, here's ADHD. We sort of deal with the numbers as dimensional things and try to work with that. And we found, I think, people accuse, the issue of stigma is really a big issue. And I actually think that this approach, thinking about things dimensionally, is a lot less stigmatizing, especially to kids, than this traditional model of sort of saying, you have, that verb, you have X. And to me, someone pointing a finger and saying, you have ADHD and other people don't, that feels a lot more isolating than to say, guess what, we all have an attention span. We all have an activity level. You're here. Some of your buddies are probably over here. We can do something to kind of move you along this level, but we're all in the same boat. We're all on the ADHD spectrum. We're all on the autism spectrum. So let's talk about kind of moving up and down that curve rather than sort of saying you've got some qualitatively different thing that other people don't have. Another way that we operationalize this is that if the whole idea of traits and disorders are on a continuum, we need to be thinking a lot more than about illness. Our field, we always say that we're interested in mental health, but what we actually are taught is mental illness. And that's something that I think we have to change. And in our evaluations, we try very hard to not only look at symptoms, but to look at the entire picture, the entire environment, and to look at wellness measures, health promotion measures. So when we see a child in a family, not only are we saying, do you meet criteria for this, we want to know about how the kid eats. We want to know what the bedtime ritual is like. We want to know if they have friends. We want to know if they're giving back to the community. We want to know if they play sports teams. We want to know if they're playing 6 hours of video games a day. And all of those things sort of go into our big picture assessment or diagnosis, because that will guide what we do about it. Just like if somebody showed up to an intern's office and you just barely made you crossed that line into hypertension, you were just over the threshold, that internist probably wouldn't be handing you a boatload of medicines. They'd be talking to you about salt and talking to you about exercise. Psychiatry needs to be doing the same thing. And that's not to say that medicines don't have a role, but it needs to be considered in the broad, in the big picture. And I think this is really one of the ways that temperament really can affect how we look at the world and how we handle families. The other thing is about bringing the parents into things. And I'm always really careful when I talk about parenting, because parenting is really hard. I consider myself to be a pretty good parent, but certainly not a perfect parent. And I've gone to these lectures, and I've heard people talk about, you should do this and you should do that. And I've left and I've said, the best thing for me to do for my kids is to get that person to adopt them. And I'm not really sure that that's the most helpful way to look at things. Psychiatry had an era where we blamed parents for everything. And that wasn't a very proud era in my view. But I would argue that lately, in this era of brain physiology and medications, the pendulum have swung too much to the other side, I think. Parents have become almost irrelevant. And so we make a point when we teach our fellows that we really need to talk about parenting, but we need to do it in a respectful way that doesn't blame them. To say that parents can be part of the solution without necessarily being part of the problem. That it's really important that what you do, but that your behaviors, in many cases, are being pulled out by your child's temperament, by your behavior. We're in Vermont, so this analogy would work. I sometimes say that a child's temperament, just like a really big mountain, can create its own weather. And that, I think, works for people. So if you're a kid who is temperamentally predisposed to be really, really anxious or really, really irritable and really, really aggressive, what do you think that's going to pull out of the environment? Is that going to pull out the fuzziest, warmest responses in people? Probably not. So what we are trying to understand is how these interactions work, and to get parents to identify that they may have responses that are completely understandable, that are completely natural, but that may not be optimal and maybe actually fueling the fire and turning temperamental traits into bigger problems. And that's the model that we talk about. Not that you're a bad parent, but that maybe sometimes what you need to do is identify what this kid is pulling out of you, and then, what I say, hit the override button. Come up with an override response that may help move things in a different direction. And I think when we get the time to actually express it in that way, parents get it, they understand it, and they generally feel much less blamed. Because we're getting the fact that parenting is hard, and that a lot of it has to do with the child's behavior. Just like, another analogy would be, I like to use a lot of analogies, but remember a couple months ago, we all saw that 2 inches of snow paralyzed Atlanta, right? Remember that? And if you were like me, I think, what is wrong with these people? Why can't you drive in 1 inch of snow? Like, you must be really bad drivers. But if you take a step back from that, you understand that the roads are different. That they're treating the roads differently or not treating the roads differently. And that if I were trying to drive in 2 inches of snow in Atlanta, I probably would have some difficulty. And it's really the same kind of analogy. So that means, and you probably remember from parenting advice, the great Dr. Spock, for example. He always told people that what you should do is you parent naturally. Parent in a way that feels genuine to you. And I would be the last person to argue with Dr. Spock, except that I would say that sometimes, and we teach this in our clinic, you do have to parent unnaturally. You do have to parent in a way that doesn't come easily to you. And you do have to sometimes take a step out, think about moving in a different direction, and trying to move in that direction in a deliberate way. And that's what's really so hard, and that's why we try to offer support for families and support for parents. One of the things that we do in our clinic is we do mental health assessments of all the parents of the kids that we see. And we do that not, again, to blame parents, but to realize that genetics means that sometimes parents are struggling with the exact same things that kids are, and that when you have people in the same family with the same types of problems, sometimes those problems get worse. And one of the best ways to help kids is to help their parents help their kids. So putting that all together, I think this was the old way of looking at things. There was the bad parent who got angry and caused the child to have problems. And then there was the era of the genes. Now there's irritability genes. Those irritability genes can factor on the child, so now we should use a medicine, right? But guess what? Those irritability genes probably also loaded on the parent, and those child irritability genes often probably provokes the parent, and we're left with this cloud, this conflict. And the conflict actually becomes our patient. This interaction pattern that's not working becomes our patient. And no one is fully to blame for that, but no one is exempt from not being a part of it either. And this is what I think is really a key way of thinking about how temperament works in families, and a really important way to intervene in a useful fashion. So that's it. I think my summary, my main 2 points that I'd like to sort of take home is that there's really overwhelming research at this point that temperamental traits and psychiatric disorders are very highly linked, inextricably linked, not in everybody, and possibly and probably in very different ways, but there are strong relations. And that appreciating that is not merely just an academic thing for people in universities to think about and write papers about, but it actually has very, very profound implications about how we define mental illness and how we work with behavioral problems, especially when it comes to families. Thank you for your attention. So I promised I'd leave lots of time for questions, and I did. I left 30 minutes for questions, so please, yes.
I believe that one of the reasons that people are so interested in this right now is that with so much brain research coming out showing, the impact of, brain chemistry, head injury, lead exposure, all kinds of things on people's behavior and violent crime, things like that, is that it begs one of the most fundamental questions we ask ourselves as humans, which is, do we have free will? And so my question for you, starting on the spot, given your research or experience and all of the stuff you've been talking about with the brain and the impact of the environment on our behavior and those cycles, do you believe we have free will?
Wow, so did you all hear that? It was just a light question about whether or not we have free will. I do believe in free will. I do believe that people make choices, but that very often the deck is stacked in particular ways to make certain choices much less available to people. But I personally am not ready to chalk it all up to destiny or brain science that way. But welcome other opinions. Yes?
This is sort of maybe more of a public policy question. I'm getting my master's in psychology, so I just know enough to be dangerous right now. And I work at an alternative school for kids who are on IEPs, and their primary code is emotional disturbance, and they're in middle school. And throughout the last 3 years, what I've come to see is that the school systems just don't have the capacity to deal with the problems these kids present in an effective way. And you see families, and do you have any thoughts on that?
Yeah, so the question is about the challenges that schools are faced trying to help kids who have significant emotional behavioral problems. And yeah, I know the schools are working very hard, but a lot of times the outcomes are not as good as they would want. I think that more attention needs to be, as I was saying in the talk, to be devoted to working with the entire family, and in a productive and non-blaming way. And I think that there's not enough of that. I think that there's a lot of psychotherapy and counseling, which is basically sort of one-on-one with a therapist or a school, and they may have a great teacher, and they may have a great hour with a teacher or a great hour with a counselor, and then they go back into an environment where these cycles are continuing. So to me, I think just more effort looking at the entire environment that a kid would be in is where we need to go. Other questions? I couldn't have answered everybody's question. Yes, ma'am.
This will be rather strange, but I feel that nutrition has quite a bit of influence on behavior, because if you take the way people eat now, and let's say 60 or 70 years ago, the food has changed very much. Customs have changed. Children are drinking now a lot of soft drinks. They eat all sorts of food that they really shouldn't be eating at all. And I think that has a certain influence on behavior.
Yeah, so the comment is about nutrition. And I mean, I would agree. I think nutrition is an important influence. There was a study, and I summarized it on my blog, that looked at that, and they did find a significant impact of different types of diets on mental health. I don't think it's the whole story, but I think it's, and I'm not saying you are either, but yeah, I think that's important too. We always ask, a lot of kids with attention problems, one of the most important questions that we ask is about breakfast. And for kids who already may be predisposed to have attention problems, a lot of them are just running to school and not eating anything. And that's certainly not that making their attention span any better. Yes, ma'am.
Sort of focused on children, and I'm just wondering, as far as the interaction between the disorder, what is the biggest thing you say would be different from what you said about adults?
So the question is, I focus a lot of my talk on kids, so where would be the biggest differences if we talk about adults? I don't know if I would make any major differences for adults. I mean, I think, instead of talking about parents, we may be talking about spouses or their own children. So I don't, a lot of the research I was quoting, it was in adults. So I don't know, I wouldn't modify it a whole lot, I think. Yeah.
Could you talk a little more about how you mediate family conflicts? Maybe kind of mention like what are the most salient what problems you encounter, and how do you make sure that what you suggest, what you suggest is implemented.
So yeah, it's a great question. So it's a question about, so what does it look like when you're trying to talk about conflict? So one of the techniques we use is to really try to break it down. I mean, to really get a blow by blow. We'll hear, instead of hearing, oh, Johnny had a temper tantrum, and then they got a timeout. Let's really try to break it down in terms of every step. And in doing so, you often sort of reveal thoughts behind. There are specific suggestions or innuendos, and you can do sort of a chain analysis, and you can really understand how temperament is interacting, how buttons are being pushed, and then there's an opportunity to sort of say, well, at that moment, was there a possibility of doing something different? And we approach it from this interactional standpoint, so that everybody's contributing to how this happened, if that's how it happened, and often it is, rather than sort of pointing fingers at one person. And it often does reveal places where there are opportunities to diverge in different ways. Yes?
So a question about the kind of dimensional Octomach scale that you showed, which I think is very progressive, and I think it's a really good idea, but I'm just wondering what your experience has been with like billing and like politics and comparing this with the DSM and the reality that like hard enough to bill for anything, especially something that's fuzzy and like I can't imagine trying to get reimbursed for Medicaid for like being at the 85th percentile for this trait. So in the end, in the end, are you just kind of stuck with the system and forced to give people the stigma of diagnosis, or how does that interact?
So the question is, how do you work dimensionally in a binary world? I guess is a nice way to summarize that. We're not trying to protest against this. I mean, we will use codes, and we will put down. You have to put down on the billing code specific diagnoses. So in some ways, we're still doing that. It's just that the way we think about things and the way we talk about things just doesn't have that. It just has a different character to it. So we're not, so we are still billing. We are still using diagnoses, and parents are really different about what they want. I mean, there are parents that will come in And they really want they really want you to use the diagnosis, and I get that. Sometimes a diagnosis can allow a lot of good things to happen, a lot of resources to be mobilized that you don't get unless you have that official diagnosis. Other times, parents really don't want to use any labels, especially any psychiatric labels, and I try to honor that as much as I can, although one thing I will point out is that people will always use labels. And if you don't like psychiatric labels, then you hope you like other kinds of labels. Like if you don't like ADHD, then you have to like lazy better, right? Because people will still be using words to describe the behavior. They just may be using different types of words. So we don't get around behavior. And then how you use labels, because I get asked that too. I mean, is it bad to sort of say your child is shy, right? Maybe the temperament labels are just as bad as a diagnostic label. And what I try to do is use the temperament terms in terms of behavior, not in terms of who you are. Like we've all now been conditioned that we no longer say you're a bad kid, right? We don't say that anymore. We say you're acting badly, right? Or that behavior is inappropriate. So we can apply that same kind of logic to temperament, and instead of saying, "Oh, you're a shy kid," you can say, "Oh, you're acting shy." The implication being you're acting shy right now. And maybe you will or maybe you won't later on. It's describing the behavior, not the core of your very being. Language is important. Yes, sir.
I don't know if this is an appropriate question here, but recently at least, mass killings have been conducted by males. And I'm wondering, the question comes to mind, are there certain mental illnesses that male flippers?
So the question is about disorders being more predominant in males. Yeah, and in fact, a lot of the disorders that we deal with, especially in psychiatry, have big differences, and they can go in either direction. So ADHD, for example, tends to be more apparent and more common in males. Eating disorders tend to be more common in females, and then things can be even more complicated in terms of the male-female ratio can change over time. So, for example, anxiety disorders for little kids has about the equal male-female ratio, but when you hit adolescence, more females than males then. So it's a moving target, like a lot of things. Yes?
I'm curious about borderline personality disorder. If you could just speak to that, or maybe even give me a book to reference.
So the question is about borderline personality disorder. Well, borderline personality disorder, as the name suggests, is in this group of disorders called personality disorders, which are sort of in this in-between land between, what used to be called Axis 1 conditions like clinical depression and traits. And the idea about borderline personality disorder is that these are folks who struggle with regulating anger, issues of abandonment, seeing the world in sort of polar opposites, all good, all bad, having identity disturbance, and these tend to be kind of pervasive, long-lasting difficulties that they struggle with for a long time. And there are other personalities that go along with obsessive-compulsive personality disorder, maybe some. So I don't know if I can give you a great book, maybe other people off the top of my head. In child psychiatry, we tend to not use personality disorder diagnoses. We just don't apply them. That's always been our practice. The idea is that a personality is changing so fast, I guess, that you don't want to label it as being disordered. So it's not something that we use very often.
There's a reference on the resource list for personality disorders publication.
Ah, there you go. Yes.
I can't remember the name of the author. If you're looking for a good layperson's guide to borderline personality disorder, there's this book that came out, I think, in the early mid-90s called I Hate You, Don't Leave Me. It's been updated. I think it was updated in 2010. It's not bad. It's intended for the layperson, but it's a pretty good introduction.
Yeah, I've heard of that book too. I haven't read it, but I've heard of that book. Yes.
So many moms are working today. What impact does it have on the children?
To have kids, in other, working with or being cared for by other people. Well, the answer to that is the answer to everything in psychiatry, which is it depends. there was a very big, well-funded study from the National Institute of Child Health that looked at that question. And the bottom line, as I can tell, is that it really depends on the quality of the child care. So that if young kids are in a really good setting and they're receiving a lot of support and nurturing, and those kids, you really do not see many differences in terms of, and in some ways they're actually sometimes doing better in some ways. If you're in conditions where the child care situation is not so good, then that's a very different ballgame. So you can't just sort of say, is it better or worse to be brought up by, a parent versus someone else, but it really depends a lot on the quality of the child care. Yeah, did you have a question right behind?
I first had a question, but I just wanted to say to the lady who asked about borderline that NAMI National and NAMI Vermont National Alliance for Mental Illness has a whole booklet on person at borderline and a lot of references. So if you contact NAMI Vermont, you can get some info. It's not a huge book. But my question was, I wondered if you agree with my theory as to why there seems to be an increased incidence of autism, which is the paternal age effect. Since because women are tending to delay childbearing and pursue careers first, and they tend to have, the fathers tend to be older also, and there are about all these studies that were for that, and then it came out for schizophrenia as well, which is another topic. And I wondered if that could be causing some increase in autism.
Right, yeah, so the comment is, could there be other factors, especially increasing paternal, people are having kids later in life, and is that maybe increasing the risk of things? And I think, yes, in this particular case, there's pretty good evidence that paternal age has an effect. It's not a huge effect. So I don't think that that's the whole ball game. But I would agree, yeah, I think that is one of the reasons why we're seeing higher rates, and it's probably a true higher rate, at least for some of these cases. Yeah.
One more question. What about love? When the children know that they are loved and understood, they have a very good relationship with everyone around them, and they are much less likely to have problems.
So the question, and I'm so glad you brought it up, is what about love? And I think that that's just beautiful. In fact, I was in Tucson a couple months ago, rolling out to a group of other training directors of a new course that we are going to be rolling out to our child psychiatry fellows. And it's saying, basically it's about positive things. And the idea is that we do lots of teaching about all these bad things. We teach about trauma and about brain injury and about we need to also teach people about good things that have to do with mental health. And so love is actually one of the lectures that our fellows are going to get. And I think the way you're thinking is the way I'm thinking. We need to do a better job of talking about real mental health, not just mental illness. So thank you for bringing that up. Yes, ma'am.
That actually brings up a question for me, which is, and I don't want to disparage your comment at all, but my sister has a child with Asperger's, and my sister loves her son so much and showers him with love every single day. And she is so frustrated because no matter what she does, no matter how hard she tries to do the right thing, it's so frustrating for her because he still has tantrums and issues and has so much pain and so painful for her. So my question is, how about the parents in terms of, you're talking to them about involving their family, but they need support too about, like, this is so hard for you to see your child suffering, and what kind of support is available for them?
Yeah, absolutely. So I think a really good comment. Sometimes love isn't enough, and even under the most loving circumstances, there'll be plenty of kids who will struggle. And in those cases, we really do want to try to support the family. Parents always blame themselves for their kids' behavior, and we really need to help them understand that it's much more complicated and that families need a lot of support. So yes, I would certainly agree. Did you? Whoops. Ooh, good thing I put the cap on. Yes.
I work with kids with disabilities and their families, and I recently came across a family with a 12-year-old with Asperger's. And the families at this time, they know the diagnosis. He receives different resources because of the diagnosis, but
Yeah, so the question about when would you bring up a label, well, in Asperger's, has officially disappeared. So now it would be autistic spectrum disorder. Yeah, right. So in general, I mean, I'm sure that the reason that they're holding back is out of concern. It's for a lot of right reasons. To me, the trick is not the label, but how you articulate what that label means and what it doesn't mean. And I often find that sometimes it's good to bring up complicated issues with kids really early because they won't get it. They'll take a little piece of it, and then you bring it up at another point, and then they'll get another, and it gets incorporated in a way that can be more, like adoption is another time that comes out. When do you tell your kid is adopted? And so, I mean, I think maybe just a discussion about what their concerns is, and is there a way to bring up a term without it meaning as much as maybe they think it means, and this is where I think the idea of a spectrum is really. I mean, we are all on the autistic spectrum, and so if you can articulate it that way, and a parent could say, yeah, I'm here, I'm a little quirky here, and you're kind of here. I think in some ways that can be less blaming and less stigmatizing. Yes, up in the back.
I just wanted to ask you, in adolescent psychiatry, the use of ECT and its success rate?
So the question, I get a question about all kinds of stuff. So a question about ECT in kids. I don't do any of ECT in kids. I think it's a very highly specialized sort of last resort technique that is done only in a few places across the country. As far as I know, there's no adolescent ECT being done in Vermont. So it's kind of used as a last resort, and people may argue that maybe it's being used too much of as last resort, but we don't have it here. Yes? I actually picked her, you can go next.
How do you think that the environment that a child is in, so whether it's a really urban or natural environment, impacts their kind of traits and behaviors?
So whether a child is grown up in the middle of a city versus so the question is, how does that impact that? I'm sure it impacts it a lot. I can't point to a study and sort of say, this is how, this trait is different depending on the environment, but you got to think that it does. And this is another place where the fit actually might be really important. So if you're a kid who temperamentally gets really overstimulated by a lot of sounds and stimuli, then your response to being in the middle of a big city might be very different than a kid who loves a lot of excitement around them. So this might be one of those great examples where it's really a fit question as opposed to a certain environment being good or bad, more universally. Yes, did you have a question?
So I worked at Harvard Center. We attended a training the other day for developmental trauma, and she was talking about there's a lot of similar symptoms between autism spectrum disorders and like pervasive developmental disorders and symptoms of developmental trauma on an otherwise neurologically typical person. Have you experienced that in your practice?
Yeah, so the question was about overlap between lots of different disorders. Yeah, and I think we're finding this more and more. There actually was a big study that came out that basically showed that the genes for lots of different varying conditions, that the genes that conveyed risk from everything from autism to ADHD to schizophrenia, to some degree were shared. It's the same genes that are being involved. And so, that would fit. And I think environmentally, the same factors would work the same way. Is that what you meant? Is that answer your question?
I guess so.
I guess what I would say, because the trauma question comes up a lot, is I think it's very easy to sort of say, oh, this can't be ADHD because this kid experienced trauma. And to me, I think that there's some fallacies with that way of looking at things, because we know that if a child grows up, a child learns how to regulate themselves and learns how to pay attention when they're very young. And if a child is being abused or neglected during that time, that brain will be rewired differently. So, but by the time that they're 6 or 7 or 8, their ADHD is just as much of a real thing as a kid who may have just had those genetic influences. So I sometimes question this idea that you should go off in a different direction because you are attributing some specific cause that happened 10 years ago to why those traits happened. There's no evidence that ADHD that you think is caused by developmental trauma responds any differently to the types of treatments that we have versus a kid who's never experienced trauma.
Would they have maybe a higher potential for treatment? Like if they're more able to recover from?
It might, but their data have not shown that yet, and we don't. We used to think of, in depression, we used to think there used to be like reactive depression that we thought was caused by this bad thing that happened, and then there was, quote, biological depression. And the idea was that you'd use therapy for the reactive depression and medicines for the biological one. And that never turned out to be true. It turned out that medicines work just as well for reactive depression, and psychotherapy works great for depression that kind of comes out of the blue. So this idea that we're matching this up, it makes sense, but it hasn't held up. So I think we've got maybe two more questions, and then we'll wrap up.
Professionally, is there something that you wish you knew when you first started out that you haven't talked about today? that it's the old thing of what you'd say to your younger self. And I guess, other than what you talked about today, is there anything that comes out from your experience that you'd like to share?
So the question is, what do I wish I had learned or done differently earlier? What I wish I had learned a lot more is about this whole idea of true mental health. What are the things that make kids and parents do well, as opposed to just what can go wrong and what to do about things when things are going wrong. It really was not a part of my training, and I think I've suffered for it, and I think we've all suffered for it, and I'd like to bring that back. Yes, sir, last question.
There are some adults, and there are some conditions that are better treated by psychodynamic therapy rather than behavior therapy.
So the question is, are there different types of disorders that are better treated by psychodynamic treatment versus cognitive behavioral treatment in adults, right? So I just heard a talk on this. I think there's more evidence, there are more studies that support cognitive behavioral therapy than there are for psychodynamic studies for different things. Psychodynamic therapy has been helpful for things like personality disorders. I think there's been a literature for that. I think the places where cognitive behavior therapy have really shown to have a leg up are things like obsessive compulsive disorder, and then maybe for things like more aggression, and certainly for kids for more oppositional and defiant behaviors. The cognitive behavioral approaches seem to have some more efficacy. So, all right, I'm happy to take questions later. Thank you all for coming and for your great questions.